Thank you very much, Nouman. Bismillahirrahmanirrahim. Those of you who don't know me, my name is Mohyuddin. I'm a cardiologist. I practice in Lahore at National Hospital in DHA. So I recently spoke about this topic at the Fellows course at Pakistan Live, and the same talk I gave in 9 minutes. And I told the audience, bear with me. And now I'm going to give the same talk, I guess, in the next 30-40 minutes. And I will again say, bear with me, because as Nouman was saying, the topic is a bit boring and a bit neglected. It's not as sexy as bifurcation or TAVR or mitra clip, or for that matter, all those fancy cases which we are seeing in the recent days from Salman's lab at UT, which was my alma mater where I was trained. But whether you're doing a CTO or you're doing a TAVR, all of us are getting exposed to radiation, and none of us is getting younger by the day, and the effects would be seen in a few years, and we'll have few of our colleagues which will be lost to this radiation hazards as the time goes by. So without further delay, we'll start. Okay, now my slides are stuck. Can you help us? Okay, we're moving. So ionizing radiation can be harmful. Everybody knows radiation harms, whether this is a nuclear plant, whether it's a radiation worker there, or whether it's a radiation medical worker. So, but this is one of those topics people don't know, talk about it and don't pay too much attention. So that is very important take-home message that we need to drive to our younger colleagues and to all of us also who work in the cath lab every day. So this talk I have split in 4 parts. So first is quick ABC of X-rays. Second one is an occupational risk in the cath lab. Third one is radiation safety basics. And the fourth is how we can optimize the radiation safety in the cath lab. And this fourth part is about, I would say, 30 to 40% or maybe 50% of the talk, and the most relevant or most pertinent to our everyday practice. So we have different types of radiation. Which are the ionizing radiation? Ionizing radiations are the one which have enough energy to knock an electron out of its orbits and in an atom, and that's how they create an ion. If we remember from our physics, that once you knock an electron out, you form an ion. Now, not all the radiations are ionizing radiation. There are several of non-ionizing radiation, which we have in radio waves, we have in microwave, even LED lights, our cell phones. All of these are non-ionizing radiations and not as harmful as the other ionizing radiation. Now, what are the different types of ionizing radiation? We have alpha, beta, and gamma. Gamma is the one that we have to be most worried about, that we are exposed to every day in the cath lab. So alpha rays are the one which would not penetrate the paper. Beta rays are the one that can penetrate the paper, but not the human body. And the gamma rays are the one which will penetrate the human body, but will be impenetrable to the lead, that the shield would protect us from that. So it's the gamma radiation that we are worried about. So this is a very typical fluoroscopic unit that all of us are aware with, that this is the source, this is the II, these are the monitors, X-ray table. So why are we worried about the radiation? It's mostly because of the scatter radiation. So here is the subject or the patient lying right here on the table, and this is the X-ray tube producing the radiation or the rays, and this is the image intensifier. And then you have scattered radiation, which is the main source of radiation exposure to the operator and the staff. Now, the scattered radiation are different types. So this radiation from the penetration standpoints there are complete penetrable radiation. They'll completely pass through the tissue and an image is recorded. So this would result in the second form of radiation is which will be totally absorbed in case by the patient's dose. And the third one are the partial absorption, which would result in the scatter. And the scattered radiation tends to degrade the image. And this is the primary source of radiation exposure to the operator as well as the staff. Now, how do we measure this radiation? So we use this read R.E.E.D. So radiation, exposure, absorbed dose, and dose equivalent. So how does we measure the exposure? Exposure is measured in coulombs per kilogram. Now the absorbed dose, which is the second step, is measured in grays. And the last thing is the biological effect. That would be an equivalent dose that would be measured in sievert. This is the number that we are most, I would say, exposed to or familiar with. This used to be a standard system way back when they would use Rongen or RADs or REMS. Now, mostly it's used system internationals. So here the exposure would be measured in 1 coulombs per kilogram. Dose would be 1 gray and the dose equivalent would be 1 sievert. Now, how does gray differ from the sievert? So sievert is very similar to gray, but it takes into account the potential ability of the radiation to cause a biological effect. And this is the biological effect that all of us are worried about, whether it's exposure of the skin of the patient or whether this is a stochastic effect to our body resulting in a cancer, God forbid, in several years to come. So coulombs per kilogram is the exposure, and this is the amount of ionization in air due to the gamma X-rays. Then the absorbed dose in case of material is the amount of radiation energy absorbed in the material. And subsequently, it's the human body equivalent dose that tells us how the biological effect is measured in sieverts. So absorbed radiation dose is grays, biological radiation dose is sieverts. So so we have talked about the X-rays. It's not a detailed talk, but some basic idea now we have gotten. And take home message from the first part was that the gray is the absorbed dose and sievert is the one that would tell us about the biological effects. Now, moving on to the occupational risks in the Cath lab. Of course, because of the radiation, we are exposed to cataracts and cancer. And again, with the lead orthopedic strain is a big issue. None of us want to be like this several years down the road where we're using a walker and barely bent over, and spine issues are a big issue. There's a term that we call this is an interventional back or interventional back disease. Another thing about radiation is that we don't feel it. And your exposure today may not be felt for years to come. And radiation-induced cancers have a biological latency of more than 10 years. So you're doing all these cases, and whenever we have difficulty, you want to get the stent in or get the wire in, and you're moving the shield away. So you're not exposed to it. You can't tell anything. It's just like a nail in the foot. You'll be leaving the case and running out. While this thing, which is may give you a cancer in a decade or so, you will not feel anything, and you will have these latent effects in the years to come. There are several studies which show that IC and IRs are the one who has the highest amount of radiation exposure and have the highest number of radiation-related cancers also. Now, radiation exposure on the left side is almost double than on the right side, which is understandable since we stand on the right side of the patient and the left side is more closer to the tube. So you can just imagine how much the distance plays a role. Like you have barely a millimeter distance difference, and how much the radiation exposure is almost a double on the left side as compared to the right. And there is a study out there which shows that left side of the brain is exposed to twice the amount of radiation as the right side. And this study of brain tumors, the interventionalist, where the tumor location is 86% on the left side as compared to the right side. Now, how much is the radiation? And I think the best thing to measure is, and this is a slide very commonly used in different radiation talks, I'm pretty sure you must have seen this slide before, is to observe with a common chest X-ray that all of us have gotten it done at one point or another in their lifetime. So chest X-ray, the effective dose is 0.02 millisievert. So in a simple angiogram, your dose would be like 5 to 7 millisieverts. So that's almost 300 to 350 chest X-rays. Now, this is a dose given to the patient, but you could well imagine how much is the radiation exposure. Now, if you're doing a simple plain angioplasty, again, 12 to 15 millisieverts, 750 chest X-rays. Now, you're doing a CTO, it can go up to 70 to 100 millisieverts. That's like almost 4,000 to 5,000 chest X-rays. Maybe again it's about 7 to 9 millisieverts, 64 coronary CT is 15, but I think the technology has evolved a lot and they're almost close to maybes at this point in time. So this gives you a good idea that the patient that you bring to the lab to do an angiogram, he's getting exposed to about 350 of the chest X-rays. Now, this again goes back to our basic physiology. That what are the two types of effects that the radiation causes? One is a deterministic and the other one is a stochastic. And these are the biological effects of the radiation. Now, these deterministic effects only occur above a certain dose threshold, and they result in hair loss, skin damage, tissue necrosis, cataracts, sterility, and decreased WBCs. While stochastic or probabilistic side effects does not have a dose relationship. They result in cancer or genetic defects. So stochastic effects have a chance of occurring at any range of dose, and they will happen at a latency, at a later stage. So some examples of deterministic effects that you see, this radiation skin deterministic effects. So this is a patient who had 11 grays of radiation and showed up 1 month after that with a dry desquamation of the skin. And then this is a patient who had 18 grays of exposure, which was calculated at peak skin dose and resulted in skin necrosis at 6 months. This again is another example. This is a patient who's very close to the source, that is very close to the tube. So the wound on the right back healed into a scar, which ultimately required surgery. The arm was very close to the X-ray source, and there was an angulation that made it even worse. Again, this diagram or cartoon shows us how the stochastic effects work. What we know is that radiation would cause a DNA damage, and hopefully our biological systems will repair it. But if it's not repaired, then the cells will divide into and form a cancer cell, which can go into uncontrolled manner and ultimately cause cancer. Few of these numbers, or the terms, I would say, not numbers, that we are very familiar with, and depending on what software your cath lab is using and how much you have paid for it, these numbers do show at the end of the case. One that we are the most familiar with is the fluoroscopy time. The other one is the AK air karma, and the third one is the TAP dose area product. Again, I would spend like maybe a few minutes or a minute or so describing them. So fluoroscopic time, that is kind of the most common thing that we are known and people record it all the time. But this considered alone would underestimate the total radiation dose received because it does not include the sign acquisition. And that's where the major bulk of the radiation is. Air karma is again raised. This measure again has been closely associated with deterministic skin effects that I just showed you different examples. So air karma is basically the cumulative air karma is a measure of X-ray energy delivered to the air at the interventional reference point, which is 15 centimeters from the isocenter in the direction of the focal spot. And I'll show you a diagram for that here. So here you have the II, here you have the tube, and this is your isocenter and 15 centimeters from which is the interventional reference point. So air karma is the measure of the X-ray which is delivered there. And basically this measures how much skin damage or the deterministic skin effects can happen. So a certain number, when they go above, that would be considered a centennial event. So I don't know about the EP now, but back when I was doing the fellowship in 2007 or 8, the AFib ablations would last like 4 hours long. And if the case would go above certain grays, they would definitely document it and call patient every week to check their skin and whatnot. Now, dose area product DAP is the last thing that we see sometimes on the monitor if your lab has that capability. So what this shows is that this this monitors the patient dose burden and is a good indicator of stochastic effects. So the one that we will see after several years. We have gone through this slide. So now we're going to talk very basic about radiation safety basics, and then we're going to jump on to optimizing radiation safety in the cath labs. So what are the basic principles for radiation protection? So there are 3 that we deal with. One is justifiable exposure. Other one is ALARA that all of us are familiar with. And third one is the dose limits. So what is the justification? So all of us know that we have these AUC appropriate use criteria that are out there. And I remember that I think they started in about 2013 or 14 that if you have to do a PCI in USA, the cath lab staff would put a form in front of you that would say, is the patient on 2NT inguinal? What are the high-risk findings on thallium scan? And then you have to like have all those criteria checked. So you will justify the PCI to be performed, or you have an FFR or some form of justifiable thing. It's not that you're just looking at the lesion unless it's an ACS. So justification is very important, whether the benefit of this use of radiation outweighs the risk. And the next thing would be, as I said, ALARA, which will be optimization, that as low as reasonably achievable. And then final are the dose limits that we stay within the prescribed dose limits. And AHA does came out with a statement back in 14 also with that good approach to enhancing radiation safety in the cardiovascular imaging. And this was the time when all those AUC criteria came out also. So as I mentioned that we need to keep it as low as reasonably achievable. And this is ALARA is a concept that's used across the board for the radiation, whether you're working in a nuclear plant, whether you were working in a PET scan lab, whether you're working in a thallium scan lab or in a cath lab. So these are the some numbers that they have been used. That is a 20 millisievert averaged over 5 years. And then you have 30 millisieverts maximum in a year. So either 30 in a year or 20 over 5 years. Now that does not include the lens or the skin or the arms, which can be as high as 500. The lens, they say, is about 150 now millisieverts per year. So now we're going to move to the main talk, how we can optimize ourselves. So we have talked about the radiation basics and what are the basics that have to be used to prevent us from that. And now what the real things that we have to do in the cath lab, the practical part of this talk. So we have these three main things that we have to use, or the three principles. These are the three basic considerations. One is time, second is distance, and third one is the shielding. So you need to use appropriate shielding, keep a distance as safely as possible, and decreasing the radiation time to be important. Other thing I would say is we need to keep thinking about it. If you stop thinking about it, you need to think about your patient, you need to think about your procedure, you need to think about other things, how the procedure is going, but you need to keep in the back of the mind what the radiation exposure is and where your shields are, how much cine are you using. So first thing begins with a dosimeter. So dosimeter is the measurement of the radiation dose received. It usually measures into three things. One is an absorbed dose, equivalent dose, and effective dose. And this is kind of the same extension that I've talked about. Absorbed dose is the energy absorbed per unit mass. That is measured in grays. And then you have an equivalent dose. This is the effect of absorbed dose due to different types of ionizing radiation. And that is measured in sieverts. And this is, you have the absorbed dose and you multiply it by the weighting factor. And then you have an effective dose, which results in sieverts, which is reported in sieverts. And this is the equivalent of, which is equivalent dose, which would be multiplied by the weighing factor. Now, most of us are familiar with this dosimeter. That is the dosimeter that is being put under the lead apron. This is a personal dosimeter that is put behind the lead apron. I think most of the labs at least carry this. Preferable is to use at least two dosimeters. That is one above and one underneath the apron. So they allow the risk determination for the deterministic effect. That is the cataracts, this one, and the one stochastic effects, which is the underlying one that is present there. Now you do have optional lens dosimeter and you do have optional finger. There's a ring that they can place on your finger. When I used to do peripheral and we had to do an antegrade stake or do a pedal stake with the II or the fluoroscope is right on top of your hand, the lab would encourage you to wear this ring at that time. So the first step that I have told you is that you think about the radiation all the time. Number two, you use those three principles. And then the third one is definitely adapt a dosimeter. If you can't get all these fancy dosimeters, you should just have one personal dosimeter that should be put on your scrubs or whatever clothes you are wearing beneath your lead apron. And then those numbers should be measured every month or whatever your radiation department there tells you to do. These are real-time monitoring. I personally have not seen them in States or even here in Pakistan, but these real-time radiation monitors could be placed in cath lab, and this enables the staff to see their level of exposure anytime. And it can alert them when their levels are spiking. This could essentially be reset after a procedure, or this could be looked at every so often, and there could be certain alarms that could be set there. I think they would come in very handy, but again, I don't have a personal experience with them, but I'm pretty sure some labs, even in Pakistan or abroad, should have these. Again, a very important slide that all of us need to look at. So this is a term that we need to look at, that is subject image distance. It's called SID. So you want your SID to be low. So this is your II, this is your subject. So you want your SID to be low. So this is the preferable position. What is a preferable position? That the patient should be placed away from the radiation source, that is the tube, and it should be the close to image intensifier, II. So most of us, if we go back today and do our cases, we are kind of doing most of the times the opposite to it. Our patients are low and II sometimes go up. So this is the second position. So this is when you have one dose unit. Now this is the second position where your SID is kind of the same. It's 30 centimeter versus 30 centimeter here, but your patient is closer to the tube. So a lower table setting without changing the source intensifier distance results in a higher dose due to proximity of the patient to the radiation dose. So the source to skin distance is short and the patient image intensifier distance is large. That is the one that would result in more radiation. So here, this is the worst position to be in. Now your SID is increased, it's 60 centimeter, and you are relatively close to the radiation tube, may not be as much. And here your dose is 2.6 dose per unit. So the ideal position, if we can, is the patient to be close to the image intensifier, furthest away from the tube. So low SID is a good thing for us as interventionists. Thin versus thick patients. So thin patient or thick patient affects us, I'll tell you, in a lateral position and in the AP position or all the positions. For a larger patient, operators commonly increase the SID. Why? They lower the table to facilitate the size of the patient because the patient is big. So you want to get them in the picture. And this results in high patient attenuation, which contributes to an increase of the patient dose and also increase scattered to us. So thick patient, again, I think we should try to use the low SID if we can. Again, if you look at the thickness, now you have, whenever possible, sorry about that. So whenever possible, if you have a very thick or fat patient, try to minimize the angulation. Actually, we use it all the time. We have to see a stent in the balloon. We bring it to the AP to minimize the angulation to see where the balloon is without getting exposed to too much radiation. So same thing here. So if you have a more angulation, just imagine. So this is a big patient, and this is the total amount that the radiation have to traverse through. If you have an angulation, let's say you are putting the now your II and the X-rays in the lateral position, how much energy radiation has to traverse through here? The thickness is always much more in this lateral configuration as compared to the AP. So what happens is in lateral or craniocaudal angulation, X-ray crosses more tissues, as you could see here. It's crossing a whole lot more as compared to here. So for this, the system has to come. So this degrades the image quality. When the image is degraded, the system increases the beam energy to maintain image quality, putting your patient for more radiation and putting yourself at more radiation. So the thicker the patient, try to minimize the angulation. Of course, we have to optimize our images and take care of the procedure, but again, try to minimize it. And again, here it shows this is an AP position. The patient is close to II, patient is away from the tube. Your SID is minimum here, and the dose is 20 to 40 milligrays per minute. Now, the same patient, still close to II, still close SID, and you are just using an angulation that brings the X-ray tube closer to the patient, much here at this part, 50 centimeters compared to 80. And just because of the thickness of the patient, the dose rate goes up to 250 milligrams per minute. So PA or AP projection, whatever you want to call it, has a much dose rate less than the oblique angulation. But understandable that for our procedures or for us to get enough information to help or treat our patients, we need to have certain form of angulations there. FOV, very important. All of us are looking at those if the balloon is inside the stent or the stent is landed at the same place. So you have a normal mode in which the FOV is large, for the most part 25 centimeter, and the dose rate is 0.3 milligrays per second. Now we try to magnify those images by decreasing the FOVs. That is, we decrease it and we bring those things in to magnify it, or we say, magnify the images for us. So we could see for the stent placement or different things that we are doing during the procedure. So if the FOV goes down to 17 centimeter, which again, you would see the diameter closes down as compared to this, the dose rate is 0.6 milligrays per second. That is, it doubles up. If you have an FOV of 12 centimeter, the dose goes up to almost 7 times. That is 1.23 milligrays per second. So magnification by decreasing the FOV, field of view, will decrease, will increase the radiation delivered to the patient and to the patient's skin, and it will result in more scattered radiation for all of us. Collimators. We are not chest radiographers. We don't need to do chest X-rays. So I always tell my technicians, hey, bring the collimators in. Whenever you could see those lungs lightening up, or those images that are coming, mostly they have not placed the collimators right. So what are the collimators? So collimator is an adjustable lead shutter that is attached to the beam exit port of the X-ray source that could be closed down to limit the area of the body that is irradiated. So by collimating the beam to the diagnostically appropriate field of view, you will minimize the radiation to the patient as well as to yourself. So here, when the collimators are not used, the more tissue, you would see a lot of lung is irradiated. Now, when you have these collimators, shutters come in, you could see this is the part that we only look at. So you could see here, this is an open beam, more tissue is irradiated, more images degraded. Again, the machine increases of the energy, you get more scatter. This is a collimated beam, less tissue is irradiated and less image degradation you see. So collimators are very important. And I think most of the technicians that I have worked here in Pakistan, they are very well versed in using them. So does moving the X-ray beam decreases the patient's body exposure to the radiation? So this definitely helps a lot. So we have two patient examples. Both of them got 1500 milligrays during a procedure, and this was a 30-minute procedure. So this is a patient where X-ray beam was not moved. And here the absorbed dose at the skin location was 1500 milligrays. Now it's the same air karma product. And this, a lot of cath labs would show this, as I showed you before, that this is the air karma product that would be at the end of the procedure. So here you have used the II, you have put it in 15 minutes, you have put it in 10 minutes, and you put it in 5 minutes. So it's 750, 500, 250. Now this would result in a spread dose, and this would result in a much less chances of patient having any skin damage to them. Now, we don't see these patients. A lot of these CTO patients that you have done, they go home, they barely have to come back and see a doctor in 3 months, and they do get skin exposure, and they go to a dermatologist, and they may not even ask what has happened to them a month ago or 3 months ago. So it does not, that means that we don't see these things don't happen. They do happen, but sometimes patient don't pick up, and we don't think about it as cardiologists that our patient has, and they're seeing dermatologists, and they may be treating them for some urticaria or some other issues. So moving the II every so often for a prolonged case like a CTO or an ablation, that would definitely be helpful, or a very complicated peripheral case also. Pulse fluoroscopy, all of us are very familiar with this. Low pulse rates lead to greater dose reduction per unit time, and it's a good thing in Pakistan. Most of the labs are using 7.5. In Western Hemisphere, we used to see 15 very commonly, and even 30 up to for LV grams and other things. So you have a 15 pulse per second where there's 7.5, and the dose reduces significantly. So a reduction of fluoroscopic pulse rate from 15 frames per second to 7.5 per second with a fluoroscopic mode to low dose reduces the radiation exposure by 67%. So definitely, if you have to use 15 once in a while, use it and then switch it back. Remember to decrease it down to 7.5 pulse per second. So keeping your position of the II, very important. So this tells us about the scatter radiation for a C-arm fluoroscopy or in the cath lab, that it's a much higher dose to the operator when you're standing on the same side of the patient as the tube. So it's in the lateral projection. So this is a patient, this is our standard working position. So if you see, if we bend over more, we will get exposed much more to the radiation. So this is a zone of 4 milligrays per hour. And this is a zone of 0.25 milligrays per hour. So the short operators receive more radiation dose to face than the tall operator. And they may want to use to stand on the platform or use a step stool. Now it's the same operator now with the lateral position where you have the tube just next to the operator. And here the radiation dose exposure is 8 milligrays per hour. You could see that. So if we absolutely have to do a lateral position for some form of imaging or lead placements in pacemaker or something like that, in that case, I would definitely recommend that one should use a shield over here because the radiation exposure is tremendous when you're standing next to the tube. So you could see here that this is a no-no. This is your lead mounted ceiling, which is right standing in the wrong place. So this should be between you and the II if you're using this left lateral position. So the lateral position is not recommended when the lead shield is not protecting the operator, and the lateral position is recommended when the lead shield is protecting the operator. Very important slide, heavy foot syndrome. So all of us need to teach our trainees or junior colleagues, hey, this does not come without a price. Do not step for fluoro when you are not looking at the screen. It's not recommended at all that the fluoro is going on and you're not doing the procedure. And if you're doing a sign angiogram and the artery is totally opacified, you should take your foot off it. Or if you're looking at the balloon inflation, you can just buzz it for like 1 or 2 seconds. You just need to keep your foot down there and irradiate all of the room. The sign dose rates are about 10 and as much as 60 for the normal fluoroscopy dose rate. I would highly encourage that most of our cath labs do have last image hold or fluoroscopy record option, and that would definitely decrease your radiation exposure considerably during the procedure. That use last image hold or fluoroscopy record, that would help us considerably. These are the shields that we need to be familiar with. Lead apron is our main armamentarium, and we need to be taking really good care of it. Protective cap can be used. I've never used it. I always used a thyroid collar. I do have a lead glasses, but not regular with it. People have used gloves and people have used gonad shields. So these were the personal shields. And then there are shields in the cath lab that all of us need to be familiar with. And there are three of them, but mostly two of them. Two of them are attached to the table, and one of them is, which is ceiling mounted, which is an articulated ceiling mounting radiation protection. And for the most part, it's either in that part of the room or in the back of the room. Very rarely seen between an operator and the patient. It's highly encouraged. And this should be right on top of your tube here, all the way down here between you and the tube. And I can tell you, most of us, if we go today back to our lab and look at this shield, which is under the table, there's a good possibility part of it would be ripped off. And again, this is again one of the very important steps. So I would encourage that you go back to your labs today and see how does this shield looks like there. Again, just a different depiction here that it shows different parts of the cath lab. And the main that I'm mentioning here is the ceiling mounted at articulated shields. And again, these two shields, one on top and one below the table, that is present there. So take very good care of your lead apron. This is our Zara Bakhtar. Since we have our army colleagues here, never put them like this. The lead does crack, and there is a way to check it. Your cath lab staff should be familiar with it, and all of us really don't want to wear the cracked leg. Always hang them appropriately and make sure that they are being x-rayed or checked, whatever is the mechanism to check for the cracks. They should be checked once a year or so, or if not 6 monthly, for the lead to be taken care of. So definitely take care of your lead apron. It's very important for our own personal protection. Now, there are zero gravity systems that are coming up. I think Dr. Tahir shared on our group, Dr. Manu Barlak is doing a case with a zero gravity system. Now, I think this will be the future in the years to come. If not years to come, maybe in the near future, actually, this system would be beneficial. It'll be difficult to adapt with it initially, but I think once you start using them, you'll get used to it. At least for the primary operator, this will be very helpful there because they are very close to it. And we saw a picture from TCT, Dr. Barlak is doing a case wearing this. CorePad 200 is an old system. I've seen this used. Mostly EP colleagues would use it because they would be taking so long doing those AFib ablations, but I think things have improved in that part also. For interventional part, I have never seen a case for CorePad, but I know Dr. Shah Mahmood, he visited us for Pakistan Live a couple of years ago. He's at UC San Diego, and he's one of the pioneers in robotic PCI in States. So this may be expensive, but I think this system, the zero gravity system, would be the future. So take home message. We have talked about a lot of things. We have talked about radiation basics. We have talked about how to protect ourselves. I've talked about what is to be done in the cath lab for the patient, for the operator. Now I'm going to summarize it. And the way I'm going to summarize is how we can minimize it for the patient and operator, how we're going to minimize exposure to the operator, and then minimize exposure to the patient. So if you are asleep for most of my talk, I would recommend that you just be awake for next 3 minutes. And this would be the gist that all of us can take home. So this is something that will help patient and the operator. And this is number one, avoid heavy foot. So don't keep on staying on the cine when you don't have to. Minimize use of sign, that is use last image hold or record fluoro, will help you tremendously. Minimize angulations if you can live without it. LAO and AP cranials are the worst views for us from the radiation standpoint, since the tube is very close to us, especially in the LAO cranial. It's literally touching our, usually the tech would tell you that it would hit your shin. The tube would hit your shin when they put it in a steep LAO cranial. Minimize use of those magnification modes by decreasing FOBs. If you have to use it, it's okay, but minimize the use of it. Don't make it a habit all the time, but minimizing those things and focusing on those things. Minimize the rate of fluoroscopy. Of course, 7.5, we can't go less than that. We can go less than that in the DSA, digital subtraction, but then again, it's a lot of radiation in that part. So minimize the rate of fluoroscopy. Keep the II close to the patient. That is low set. That is patient close to II, away from the tube. Definitely use collimation. Don't burn those lungs, because burning those lungs will get all those scatter radiation to you. If you have the capability, monitor radiation in real time. So these are the steps which we can do as an operator, which will help us and our patient. That is avoiding the heavy foot, decreasing the sign, last image hold or recording fluoroscopy, avoiding very street cranial things, and keeping low set. Now, these are some things we can do just to help ourselves by taking care of our leads that I said. Always hang them, don't put them on the table, pile them up. And then maximize the distance from the operator. You have a fellow, let them do the case, stand on their right side. Keep these hanging shields, the one which is the shield coming from the roof, that one mounted shield, and the one below the table and above in all optimal position. An optimal position is they should be between you and the tube. That's it. Keep your body parts out of the field of view all the time. Sometimes you're getting those femoral axes and looking at the femoral artery, you're doing antegrade sticks, or doing a left radial where your hands are coming all the time in the fluoroscopy. Try to minimize it. Robotic PCI can be considered. Now, there are certain things which will help the patient alone itself also. And that is main thing is that you keep the table height as comfortable for the patient, that is keeping the patient up close with a decreased set. And then every 30 minutes or every few minutes or so, vary the imaging beam angle to minimize the exposure to any specific skin area. It was definitely decrease the deterministic skin effects and keep the patient's arms out of the beam. And so this is our A-star cardiologist in Pakistan. Even if you have A-star, you usually get only 95% or 100%. So if you see here, the patient has a very low SED. II is close to the patient. The Doc Saab have this movable skirt right in between him and the tube. And his this shielding between the wall, the roof mounted shielding is right there. Doc Saab is wearing a lead glasses. Doc Saab has lead skirt apron, and he with a thyroid collar that he's wearing. He is using collimators here, and he's also using a radiation safety cap. So I think these are all, and there's a disposable shielding here also. So I hope that all of us will have our cases in the near future like this. So that would prevent and keep all of us and our patients safe. Thank you very much for your attention.
Thank you, Tayyab. Excellent talk. Covered everything very nicely, on this boring topic but very important topic. So covered all aspects very nicely. I think we have our panelists on board. Professor Hafizullah Saab, your thoughts and comments?
I was so deeply immersed in the talk. It was such a nicely delivered talk. Beautiful. I think we really, really enjoyed it. I think the bottom line was that we have to develop a culture of it. And that was very beautifully said, that we have to have a philosophy about it and the culture of it. I remember first time when I came to Pakistan, as I entered the cath lab, somebody put his foot on the pedal and I looked at him, how can you do that to me? So that was at one time. Now I think we have to really, really be very careful about it. The talk was given beautifully. I mean, extra 5 marks for that philosophy thing as well. I think these radiation monitors, let us be honest to ourselves, they are not serving a purpose that they were supposed to do it. Partly because the PNRA is not very effective. Partly because that we as in charge of cath labs have not been monitoring it. I do not know of any cath lab who actually monitor it very rigorously. And I do not know of any time when a technician or an operator has been told, no, you cannot operate because your exposure is high. Second, very important thing is about the frame rate that he talked about. And I think that was an excellent point. Let's all of us go back to our machines and check the frame rate. Mostly it is 15. Very, very rarely it comes to 12.5. It will be only experts like Sohail who will be using 7.5. And third, we do not look after our lead aprons. I think the lead aprons that we put on is just bear extra weight. I do not know how much protection that they cover. And again, the onus falls on our Cath in charges, who should be making it mandatory to check all these lead aprons, if not on a fortnightly, at least on a monthly basis. Two small points that I wanted to add was that many of our centers have got old machines. And these old machines, to produce a good quality image, use, I mean, hamara beda gharak kar dete hain, literally. So I do not know how to serve that, because people cannot afford new machines, and old machines do not have all the luxuries that Tayyab talked about, that fluoro saving and last image. So that is one thing. Second, I feel that all this radiation protection was developed around femoral approach. And now that we are using radial approach, honestly speaking, things have not moved that much. Things have not improved that much. What we had in 80s or 90s, they're still the same. So I don't know whether Sohail can touch on these 2 points on old machines and anything new that has happened with radial being the main approach. And I like Nouman, Naseer, that you're driving in your beautiful limousine. I think it's a Rolls Royce.
I wish it was. But thank you for your valuable comments. And, there's a question from the audience. I think we should address that first in terms of the pregnant females in the Cath lab. What should be the strategy for them? And, so any thoughts from Tayyab, you or the panelists?
So if absolutely they need some procedure done, which in Pakistan, for the most part, it's a PTMC, or you have a spontaneous coronary artery dissection in a pregnant female. I have done a case or two in Pakistan, actually. So of course, you have to save the life of the mother. The basic principle is the plant needs to be saved, and then the fruit comes next, which is the baby. So you use a lead apron on these patients, and all the other measures that I have said, that you minimize the sign angiograms, you minimize the angulations, and you try doing it under fluoroscopy as much as you can. Now, we are not totally free labs, like we don't have those abilities of doing IVUS. I work in a very nice private setup, but still we don't have IVUS here. So PCIs could be done just with IVUS also. But again, for you to see the IVUS catheter, you need some form of fluoroscopy to be used. So I think the basic principles and the lead shielding, and I think ALARA should be kept in mind as low as reasonably achieved.
Where do you put the lead apron? On top of the patient?
Hafizullah, if I could answer that. The maximum radiation which comes to the baby is from the scatter of the mother. So, when we do PTMC, I've been also traditionally putting a lead apron under the tummy. But the maximum radiation it comes from scatter of the mother. So I'm not really sure how effective that putting that lead is. There's very interesting talk I heard, and I'll try and get it for you and have that person deliver how to reduce radiation to mothers and what is safe. But try and delay this procedure of PTMC as late as possible. So that's the trick. Otherwise, and was one thing I must tell you, I've seen people doing a PTMC on pregnant mothers, and they try and change the procedure somehow to reduce the exposure. That actually makes the procedure hazardous. Once you start the procedure, you must treat it like any other patient. Don't do anything different. Otherwise, you might end up with a complication. So, these are some very basic things. So once you're through with this question, I'd like to make some comments about the radiation, which are very important to me. And, most of them have been covered by Tayyab very well. And I must appreciate the wonderful topic. I think we must enumerate these safety precautions from the society side and display them very clearly in every lab, so that there's a reminder. It should be nice, very obvious poster lying in every lab, so that we are reminded every day of what to do with it. The other thing is that the LV cine that we do, that takes up more radiation than the entire angiogram. So what I've started now doing is to give an injection on fluoro, and like Tayyab said, save the fluoro for the LV cine. That certainly reduces the radiation. And just remember, one step away from the radiation reduces the exposure by 4 times. So it's very important to stand as far away as possible. And the two hazards of radial versus the femoral is that there's a fatigue factor, because this puncture takes its toll. You have to bend over, concentrate very hard. Femoral is basically no-brainer. Just go there, puncture a few times, and that's it. It's done. But radial is a very, very fine art, and you stand so close. So these are two hazards, and one must never do radials if there are no good shields. And I've literally had very senior consultants working with me, and I have to force them to push the shield in front of them. And they say, sir, patient ka shakal nazar nahi aati. Shakal ko dekh ke humne kya karna? कि sir uski safety का पता चलता है, is he comfortable or not? So it's a real change of culture to use these safety measures, especially the shield in front of you and the shield on side of the cath lab. The other thing is that you must have a full breakfast, because there's data to suggest that if you have good glucose level in your system with the breakfast, you will have less effects of radiation. I wish, what we do in the cardiac society lectures is that we have MCQs at the end of it. Hafizullah Saab knows that. So I think I would suggest very humbly to the Interventional Society that every lecture should be followed by, like, we're going to have, inshallah, MCQs on radiation in the interventional exam also. So there should have been some MCQs at the end of it, so people become more aware of these things. So there are a lot of other things, and collimation and reducing the fluoro time. We must also record the fluoro time in every angiogram. And then we must display the average fluoro time of each operator so that the cath lab knows the importance of these low radiation. I think these small things will make important things for us, and we must give the same lecture to the cath lab technician. I think we should distribute this lecture to every cath lab director and tell them to go over these things to the staff and give it to them. And at that very point, Rida came to our lab, and we all know him. He's a great operator. And he said, I go to every lab and I reduce the fluoro to 7.5, and nobody seems to notice any difference. And that is so true. It's very rarely that you need to, go on to 15. And so keep the tube head away from you as much as possible. Keep rotating. And, we don't talk about burns because we probably do not do such long CTOs, but burns are something very important. But another thing is I could never figure out how to use gloves because they cannot be sterilized. And so, your A-star operator had wearing those blue gloves. I'm not sure how he could use them unless they're sterilized after every procedure. I think there are a lot of the other things. We are very poor in wearing badges, which I think I have suggested to Nadeem also, that the director cath lab should be registered with the PSIC. And he should have PSIC. The director cath lab can be controlled by Interventional Society. And he should give a report every month about the enforcement of the legislation, which the health commissions do once a year. But by virtue of the presence of the director cath lab, we should be able to communicate to every cath lab throughout the country about these various safety factors and enforcing our mutual decisions which are healthy for the cath lab. So
thank you.
Yeah.
So Sohail bhai, very valuable and important comments.
Nouman,
I like your idea of please, Bilkul, I like the idea of having breakfast before the case. So Tahir bhai, please go ahead.
Nouman, just a simple suggestion. What we do in our pregnant PTMCs, we don't take unnecessary images. We don't take pressures. We don't take any positioning of the pigtail and other things. Just we go straight away for the puncture and just cross the valve and inflate to reduce them and minimize the radiation. In our cath lab, everyone wears a badge, and every badge is regularly checked. And in a year, once or twice, some people have to be taken to the cath lab due to high dosages, due to their own mistakes. The valid suggestions by Sohail Aziz, we will like to have it discussed in our next council meeting. And Sohail Saab is also there. And we would like to implement this regarding the Cath lab directors and other things. Very important is that this lecture should be repeated, I think, every 3 months. Every 3 months in our society. And I would also suggest that Sohail Saab should also have this lecture in his cardiac society meetings repeatedly, because this topic is very much neglected, although it's boring, but very much neglected also. So repeatedly we will take care of that in such a simple manner. Tayyab has elaborated.
Excellent.
So Bilal has elaborated thing that it should be time and again repeated so that simpler things would be taken care of.
It will be available online as well for those who are interested and who missed out, so we can let them know.
But,
Dr.
should have regular 3 monthly talk of
I
this.
think not a bad idea to quarterly, as a reminder to reinforce. We should repeat these. Professor Bilal Mohyuddin is also with us, so we'll get his comments as well. And if Professor Bilal, you can answer the question as to what schedule do you keep for, we have a lot of women in interventional workforce now. So what females who get pregnant, what schedule do you have in your institution, and how to check for the cracked lead? We have all these lead aprons lying around for a long time. So do you have a mechanism for checking for cracked lead aprons? I think Bilal Sahab has joined us, so he can answer that question, and the other panelists can pitch in with that. Professor Bilal?
Assalamu alaikum. Can you hear me?
Yeah.
Yes, we can.
For some reason, it seems that the video camera is not operating.
Charlie, we can hear you well.
It cannot tolerate your beauty.
Kind of just a quick comment regarding the pregnancy first. For pregnancy, it is recommended not the 20 weeks, but the 27 weeks they should be pregnant for at least 27 weeks. This way, the neural tube development is better. But of course, some people go it even with those 20 weeks. And as Tahir very kindly suggested, this is the way we have always been doing our pregnancy cases. Then one thing that I think got missed out was that a pregnancy patient is only for the expert who can go very rapid. The days when I used to do these PTMCs on a regular basis, I could go in and be out within 5 minutes procedure time. So that was the way that this has to be done, because somehow or the other, these patients perform better. And of course, your whole management is better. As far as the coronary part is concerned, you try and shield as much as possible, and then try and go from the radial side, because then your access will be better. And because otherwise you may have a problem from going down. You want to have a clear image. So that may be one thing. Regarding your part about the various other things.
Scheduling for the women workforce, the pregnant females working in the department.
Workforce. As far as the ladies who are expectant mothers or are planning to get pregnant, now we normally ask them, please, you will be posted out of the cath lab now till your pregnancy period is all done with, because that is the safest thing to do. You cannot have a risk, and you cannot justify that risk no matter what. So as far as I'm concerned, this is has always been my work way of doing. But as far as those who are expectant and they do not know that they are expectant, so then they try to do the basics. One thing I especially would like to point out over here is that unfortunately in some cath labs, there's a tendency that the nursing staff has been asked to stand at the head end. And when they stand at the head end of the patient, near the patient while the whole procedure is going on, they are actually being exposed quite badly. So that is the idea, that they should not be standing at the head end. They should actually be standing at the foot end of the patient. Then also that if they are expectant mothers, you have got other long way of feeding. I've seen in international cath labs that they have got those long feeding lines as far as these patients are concerned. By the way, the zero gravity lead shield that was being discussed with, this zero gravity, we looked into it, it costs approximately 10 million rupees. So that is why, despite all the efforts, we were trying to get this thing, and we could not really have the whole thing.
Do you have a mechanism in your, I'm sorry, do you have a mechanism in your institution for the checking for cracked leads? I'm not aware of it, but
what we normally do for cracked leads are something very basic, that we ask our technician to scan these leads regularly. And if there are any major cracks over there, they become visible on your basic X-ray beam. And when they start becoming visible on the basic X-ray beam, then those leads are normally disposed of, or we recommend that these need to be changed. But unfortunately, the point that Tayyab actually showed in that photograph is such a glaring example by a lot of very, very experienced cardiologists, the way they use their lead. And it is a reality that many people do not bother to look after their lead the way it is supposed to be done. One thing that I would like everyone to be actually very clear about is that please, all cardiologists who are interested, this lead protection that you are talking about is for your protection. It is not about for the patient's protection. As far as for the patient protection are concerned, there are other newer means, the newer machines are there. As far as your protection is concerned, now they have got newer things coming in. They have got ankle shields coming in, like the way you have your aprons coming on. So you have your ankle shields coming in. You have your left arm cover coming up. So that is there, because though, of course, it has been believed that the bones, etc., are relatively better protected, but it is still very much over there a problem.
Nouman sir,
yes,
मैं अर्ज करूं about the lead protection. I have tried to scan these lead aprons and see and look for cracks. You cannot see the cracks. I've been doing it for years.
So what is your
if it looks
regular
ragged,
change?
Yes, if it looks ragged, and you must enforce strict discipline. Like लोग आते हैं सीनियर कार्डियो आके फेंक के चले जाते हैं.
बिल्कुल, वो तो है, properly hang नहीं होती.
There's a penalty, हम पैसे लेते हैं, 100 रुपया पकड़ाओ.
लेकिन जो ऑलरेडी लेट्स कुछ अरसे से यूज हो रही हैं वो महंगी बहुत है और टर्नओवर ये वो सारा कुछ तो इतना तरीका है. आई एम नॉट अवेयर ऑफ इट फॉर चेकिंग क्या तरीके है जिसको रिप्लेस कर लें. बाहर तो हमारी 2-3 साल बाद नहीं.
हम लोग इतने माइजर लोग हैं, हम लोग कैथ लैब्स की सेफ्टी इंश्योर नहीं.
वो दैट्स वेरी इंपॉर्टेंट. बिल्कुल,
व्हिच इज नॉट फेयर. देखिए जब when these things are maturing, तो why did the health commissions come into being?
नहीं, बट लाइक AFIC में जब आप थे तो आपका कोई मैकेनिज्म था कि 3 साल बाद लेट्स रिप्लेस करवा लें या चेक कर लें कि वो ठीक है कि नहीं, आर दे स्टिल फिट और नॉट? मैं ये जानना चाह रहा था, एज एन इंस्टीट्यूशन डिड यू हैव अ मैकेनिज्म फॉर द इनका?
देयर इज नो मैकेनिज्म. हर अदारा पैसे बचाना चाहता है एट द कॉस्ट ऑफ सेफ्टी ऑफ द पीपल, व्हिच इज टोटली अनफेयर. दिस वे द सोसाइटी should take. I think I won't mind hesitating कि हर डायरेक्टर कैथ लैब अपने लेड एप्रन्स की तस्वीर भेजा करे सोसाइटी को कि
ये बात आपकी बजाय, लेकिन माफ कीजिएगा, आप हर चीज के
अब मुझे बात करने दें बिलाल, फिर आप बोल लीजिएगा. लेट मी फिनिश प्लीज. तो देखिए हमें ना जो ये सोसाइटी को इन्फोर्स करना है, वी शुड लेजिस्लेट आवरसेल्व्स एंड वी शुड प्रोटेक्ट आवरसेल्व्स आल्सो. कि हमें अब डिस्प्ले करने ये हमारे लेड है, इनकी पिक्चर्स भेजेगा और डायरेक्टर कैथ लैब should be our enforcing end, and that's how safety. वरना ये जो इन्वेस्टर्स होते हैं ये तो आपको बिल्कुल थोड़ी सी मशीन ला देंगे, ऊपर ना सेफ्टी होगी ना ये होगा वो होगा, वो तो कहेंगे आप लेड ना ही पहने. So लेकिन this is where we have to look after our people. हम लोग जो है ना, we are like the जो उनकी होती है काउंसिल्स होती है, लेबर यूनियन है. हमारा काम है उनका, अगर इनको रेगुलेट करना है, इन पर डंडा चलाना है, तो इनके इंटरेस्ट भी देखने. I think this should become a part of the council meeting. How to look after the interest of the interventional cardiologists and the staff, especially from radiation protection and overuse and overwork. ये भी हमें इसका अदारा बनाना चाहिए इसमें.
जितनी हमारी stimulating discussion हो रही है on this boring topic, that's really nice, and but because of time limitation हमें wind up करना पड़ेगा. 2 questions थे. एक आया हुआ था साकिब शफी साहब की तरफ से कि what is the cut off radiation dose. So 50 millisieverts is annual cut off. जो अगर आप बैच पहन रहे हो तो उसके ऊपर आपको you should consider cutting back on your work or stopping work. और एक बंदे ने question पूछा था regarding having radiation committees in the hospital. I think absolutely कोई भी hospital जहाँ पे radiation use हो रही है, they should have a committee which should regularly assess के badges आ रहे हैं कि नहीं आ रहे, radiation dose monitoring हो रही है कि नहीं हो रही, सारी जो precautions हैं ली जा रही कि नहीं आ रही. But unfortunately कोई इस तरह की committees routine में hospitals में देखने को नहीं मिलती हैं और implement नहीं होती कम से कम. तो यह है कि excellent lecture by Tayyab, and I
think मैं इसमें ऐड कर दूं कि जो patients के ये जो इंटरनेशनल रिकमेंडेशन है वो 20 मिलीसीवर्ट्स की है, and that is per annum for all sorts of radiation. And
so 20 millisieverts for what? Operators की तो 50 है, 20 is
for the patient. For
patient
the patient, because a lot of these patients, elderly patients, also have their MRIs and everything. So those who are elderly patients and you suspect that they are going to be exposed a lot, it is basically a warning point for the people looking after those patients कि इनको इतना हो गया है, इतनी radiation. But of course, those who are receiving this came out from those when these patients were receiving radiation therapy as oncology management. तो उसके लिए ये चीज शुरू हुई.
Thank you for pointing that out. बाकी है कि we are all going to die of something, but we have a 20% risk of dying of cancer in general population. But as intervention cardiologists, we already 4% higher risk, 24% risk of dying of cancer. Or हम radiation protection measures नहीं ले रहे, it may even be higher. So I think we should all be mindful of that, of the stochastic effects to protect ourselves, our colleagues, or so I think the Tayyab very nicely pointed about all the collimation, the source image, source object distance, the shielding, cine ki minimal usage, heavy foot or fluoroscopy, frames kam karna, image, stepping back with each picture, all those things can help. So on that note, I think we'll wind up, and thank you everyone for participating. I think Hafizullah Saab, you can give your last word before we sign out. Yes, thank you.
The last word should come from you, but I'm just saying, I think discussing it, this lead aprons is the Achilles heel, and we cannot legislate everything. We cannot hold PSIC, but we can create more awareness. Maybe Tayyab can bring up a figure that these aprons should be changed every 3 years, every 4 years. Also, it depends upon the way people use and protect it. But some sort of a thing should come up that these aprons are not for lifelong. They need to be changed, and I think that has to be.
I think ये PSIC की तरफ से एक official document इस तरह का निकालते हैं. We're doing some more apron की change के ऊपर ये वो as a recommendation to Cath.
इसमें मैं एक चीज आप लोगों को ऐड कर दूं कि हर लेड के साथ एक थायराइड आता है, and many times people walk away with those thyroid covers, and people are not even willing to buy that thyroid cover for 3,000 rupees. So that is the problem.
I think it all goes in combo. Thank you.
Thank you very much, everyone, for joining us. And
thank you, Tayyab and Society, for a wonderful talk.
Thank you again.
Excellent.
Take care, everyone. Have a nice weekend.
Allah Hafiz.
Allah Hafiz.